Hi everyone, my name's Ken. I'm a physician up in Canada, that's why I wore red today, but you may pick up a little bit of my accent. I'm going to be talking about how to be a master practitioner when it comes to doing regional nerve blocks. Now, you don't have to be some kind of hocus pocus, and what I mean by that is point of care ultrasound, POCUS guru, to be able to do this. And in fact, none of these blocks require an ultrasound. All you need is this, and you can do really great blocks. So, let's talk about some of these blocks. Why would you do a block? Why not just dump in some local anesthetic? And when do you dump in local anesthetic, and when do you do a block? And why not just knock them out? I mean, send them down the K-hole. Who cares? You know, that kind of patient is my kind of patient. Well, there's reasons why we do local, there's reasons why we do a nerve block, and there's reasons why we actually do procedural sedation. And just, you know, if Rick can rant for 30 seconds, I'm allowed to rant for 30 seconds. Procedural sedation. Please don't call it conscious sedation. Okay, that's an oxymoron. It's like jumbo shrimp. Fresh, frozen, conscious sedation. It's procedural sedation. Okay, I'm finished ranting. Oh, and I'm Canadian, so sorry about that. All right, so, and then when you're using lidocaine, great to use, right? Nice sodium channel blocker. Great to use, all right, but you can get into toxic doses. And you can get into toxic doses pretty quickly if you're using 2% on a small person and you're doing a complex laceration, or you're doing a foreign body removal, or you want some kind of extended region, right, that you want anesthetized. And so using a nerve block is a great alternative because it's more efficient. You don't have to use as much lidocaine if you're using lidocaine, and it's more effective to get that whole region with a small amount of anesthetic. And I like that line down there. You know what? It's less paperwork. And in this case, it'll be this kind of work, right? Because you've got EHRs, but it's less administrative stuff compared to doing procedural sedation. Because procedural sedation, you know, often you need more people and more this and that, where you can do these nerve blocks and get good blocks and not have to go through all of that. So we're going to focus in on some high yield ones that you can take home and do and look like a master practitioner. All right, so here's a table that breaks down the toxic doses, because I did mention one of the reasons for doing a regional nerve block is to avoid toxicity. And so you need to know what the toxicity is. I put lidocaine up at the top there because that's probably the one we use the most. And when you're looking at it, you need to know the properties of it. It's fast acting, it's really quick. We've all put in freezing, local, and it's frozen. I mean, you're sitting there and the person's like, yeah, it's numb now. Right? So it works really quickly. The toxic dose is 4.5 milligrams per kilogram if you're using it without epinephrine. If you're using it with epinephrine, and just as a medical myth, you can use epinephrine containing local anesthetics in the tips of anything. It will not fall off, people. Okay? So it will not fall off. That's a medical myth. But it's 7 milligrams per kilogram. And so 1% lidocaine is 10 milligrams per mil. 10 milligrams per mil. If you're using 2% lidocaine, it's 20 milligrams per ml. So if you're firing in 5 cc's in an area, you've just given 100 milligrams of lidocaine. Okay, so you can get into toxicity. Also, the duration of action is anywhere between 1 and 2 hours, depending if it's with or without epi. Now, if you go down that chart, you'll see bupivacaine, and that's one I use for hip blocks all the time. But you'll see that it's slow on action. So you can't just fire in 20 of bupivacaine and do a 3-in-1 nerve block on a hip fracture and then start pulling on something. It doesn't work that quickly. You have to say, hey, listen, we're going to do this block. It's going to take some time to settle in. I'm going to just go see another patient, like if you're doing a fracture reduction or some kind of thing. I'm just going to go see another patient and come back in 15 or 20 minutes and give that time to work. But the beauty of that is it's going to last 4 to 8 hours, which is great if you've got a fractured femur and you want some extended pain relief until ortho can come out of the OR and see this patient, right? Because you know that it's going to take time until they can see them. Okay, so that's some local anesthetic toxicity. But the last thing you want to see happen is to get local anesthetic systemic toxicity. That's the last thing, and that's why I'm emphasizing it, because it's actually called last. Okay, so it's local anesthetic systemic toxicity. And the Tasmanian devil down there, the reason that picture is there, has anybody seen this? Good, because these people go, blah! Like they get psychotic, and it is crazy. Now, of course, it can start out mild with some tremors and some tinnitus and things like that. But if you get into full-blown, you can get into acute psychosis. And if they're in acute psychosis, you will welcome the seizure. Oh, good, they're seizing. Great. It's so much less stressful when they're sitting there seizing in status epilepticus compared to blah, and they're running around, tearing the place apart. All right, so it can be really dramatic. Now, it can result in death too. So that's why we need to know our toxic doses. That's why you can do a block. And a block uses less and gives you more. Tastes great, less filling. Okay? So when do you see this? When would you see last syndrome? Well, we aren't doing a lot of beer blocks anymore, but that's when you'd inflate the cuff and dump in the local anesthetic, and you'd have a cuff failure on the extremity, and all of a sudden, whoosh, all that local anesthetic would come systemically, and the patient would go, bleh. The other time you see that is when you inject directly, and you got a vessel. Oh. Okay, so you're supposed to aspirate to make sure you're not in a vessel. And we're going to show you an ulnar nerve block to emphasize, hey, there's something that goes boom, boom, boom right there. You don't want to inject directly into that. So that's the other time. Now, if you're old enough and you were in the era of the 1980s, early 1990s, when we were trying to prevent every single PVC that a patient had on a monitor, oh good, somebody's smiling over there. It's like, oh, a PVC, give them some lidocaine. Now, they found, after doing research, that preventing those PVCs, there were more people standing, i.e. alive, if you didn't try to prevent them, then, oh yeah, those people don't have PVCs, but they don't have anything anymore. Okay, so we don't do that anymore. But the classic example was, you know, the little old lady would be knitting her socks for the maternity ward while she's in the CCU for an arrhythmia, and she throws some PVCs, and so they start some lidocaine. She's knitting away, lovely woman, and oh, there's another PVC, up the lidocaine, blah! Turn down the lidocaine, knitting the socks for the newborn babies, okay? Anyways. All right, so what type of procedures are we going to talk about? Laceration repairs, especially on the face. If you have to do some big laceration or some detailed laceration, I mean, if you get a VC border, a vermilion cutaneous border laceration of the lip, and you've got to get that lip line lined up where you put lip liner, and that's for cosmesis. On the face, patients are most worried about, if you ask them, cosmesis. On the body, the most thing they're worried about is function. And if you ask providers or clinicians, it's infection. That's our number one priority. But patients have different priorities. And on the face, it's cosmesis. So if you're doing a VC repair, foreign body removals, especially in the hand, you can be digging around in there, dumping in a lot of anesthetic, digging around trying to find a piece of glass or something. You know, doing a block is really advantageous. Incision and drainage, we can freeze the roof. We can freeze the roof of that abscess for an IND. But what do you do after you freeze the roof and lance it open? Oh, I'm pushing that volcano of pus. And doesn't that hurt? And so you could do a nerve block for that, and then that doesn't hurt. Road rash, so if you're a cyclist and you shave your legs, you should, you get a road rash, you're pulling little pieces of little pieces of stone out of the hair and stuff like that, so you can do a regional block on the thigh. So we'll talk about that. Burns, debriding burns and stuff like that, very humane. All right. So on our menu, we're going to do a 3-in-1 block. We're going to show you how to do that. Easy. We're going to show you how to do an ulnar nerve block. Easy. We're going to show you how to do ankle blocks, scissor blocks, orbital blocks. We're going to stick a needle by the eye. It really works well. If dentists can do it, you can do it. All right? And then we're going to talk about the lateral femoral cutaneous nerve block, and we'll throw in a little stuff about ultrasound. But that's not the priority. So femoral nerve blocks, really, really easy. We want to give you things that you can leave today and go back to your departments and do this. All right, so a femoral nerve block, you can turn it into a 3-in-1 nerve block. Very easy. So you get the LOLs, and that stands for not laugh out loud, but little old ladies. You get the LOLs and they fall and they break their hip, right? They are very vulnerable because A, they often don't ask for pain medicine, right? They're like, oh no, I'm fine, doctor. That's what they say to me. I'm fine, doctor. Meanwhile, they've got this hip fracture. And then, in the room beside them is the 20-year-old male going, with their paronychia, right? And the doctor looked busy, right? You get that, right? And so it can be very opioid sparing. So if you get the LOL with the fractured hip, right, you can decrease the amount of opioids you need to give that little old lady. And it's very beneficial, and it can be long-acting if you're dropping in bupivacaine. Slow on onset, 4 to 8 hours of duration. You can use it for road rash, foreign body removal. FB stands for foreign body. GSW, I had to look this up. I'm in Canada, right? So that stands for gunshot wound. I've been doing this for more than 2 decades, and you know how many gunshot wounds I've seen? A full-time emergency physician in Canada. You know how many gunshot wounds? Come on, guess. It's a nice round number. Moving on. No politics. Okay. All right, so 3-in-1 nerve block. Okay, so navel. Find your own navel. No, really, find your own navel. It's right there, right? So if you spell out navel across your belly, right, the nerve is on the most lateral side. So it depends if you're left or right, right? So it's on the most lateral side. Your femoral nerve is lateral. Your lymphatics, N-A-V-E-L, navel, nerve, artery, vein, empty space, lymphatics. Your lymphatics are medial, where your glands are. So you just go below the inguinal canal, maybe 3 finger widths below the inguinal canal, and feel for that pulse. Now, if you're doing a stick trying to get an arterial gas, this is the easiest way to do a femoral nerve block, because every time I go for it, it's like, I don't hit it, right? So you go right beside, right lateral to the nerve, and you dump in 20 cc's of bupivacaine. And then you hold your finger there, just distal to that, so the bupivacaine sits there, and you can get a 3-in-1 nerve block. Now, we encourage you to discuss this with orthopedics or let them know that you've done a 3-in-1 nerve block, because they can come in and go, yeah, the LOL who fell must have had a stroke. She's got no sensation in that leg. They may not have picked up that you did a 3-in-1 nerve block. Easy. There's a cross section. Okay? You just go, you feel for the artery, and go lateral to that, and you dump in 20 cc's of bupivacaine, and it spreads out, and you get the lateral cutaneous nerve, the obturator, and the femoral. Really nice block. Now, you can do it ultrasound guided. I've done it both ways. You look for the shimmering nerve, but it's really good. All right, so that's the 3-in-1 femoral nerve block. We see hip fractures all the time. And as our population ages and gets frailer, we're going to see more and more of this. This is a great way to do that. But this is the lateral femoral cutaneous nerve. All right, now you've felt your navel. You felt, for your femoral pulse. Now what you do is feel for your anterior superior iliac spine. It's right there in the front. And if you're not sure where it is, don't ask your neighbor. Okay? It's Me Too area, right? So right there. And if you've ever seen a Calvin Klein underwear ad, on a young man, you can see those things sticking out right there, right? They're right there. They're where you bump up against things, right there in the front, okay? So just below that, and then you fan out with your block, and you get immediate relief for a lateral cutaneous femoral nerve block. Well, why would you do this? Road rash, you got a big area, a burn. It's all that lateral aspect of the thigh. You can get Meralgia Paresthetica. Meralgia Paresthetica is an interesting condition. You see it, we'll show you first. You get a pinch off of this nerve, right? Now, when do you see it? You see it with people that wear a lot of belts with tools on it. So police officers, have you ever seen current police officers? Right? It's not like the old British police where they didn't carry guns, right? It's like, stop, or I'll say stop again, right? Current police officers, they have so many mags, they've got lights, they've got pepper spray, they've got like nightsticks. They look like Batman running around with these utility belts on, right? And that puts pressure right there, and they'll get pain down the thigh. And so you can diagnose that it is a pinched nerve, a paresthesia, by doing this kind of block, and it's therapeutic. It both diagnoses and relieves. So you'll see it in plumbers, anybody who wears a big belt that's putting pressure and hanging down low. Now, the other major group is pregnant women in their 3rd trimester, and their stretchy panel pants that you wear, or the Lululemon that just stretches out, right? And eventually you get to the point, after 37 weeks, there's no more stretch left in that panel. And so what do the women do? they roll it down in the belly, and then they get this real pressure right across there, and you'll get this paresthesia. So you can give relief and diagnosis with this regional block. It's really effective. All right, so ulnar nerve blocks. This is the third block we're going to be talking about, an ulnar nerve block. Now this one's easy to find, right, for landmarking. Flexor carpi ulnaris. Okay, so deviate your hand, your wrist, deviate your hand to the pinky side, the fifth digit, and you'll feel right there. You feel that fibrous tendon right there, that thick tendon right there. Now this is one of the cases where you can turn to your neighbor. Oh, she did it. Wow, direct eye contact. Turn to your neighbor. You're going to shake hand. Now feel theirs. No, really. I mean, even if you don't know them, this is the way to, hi, how are you? Nice to meet you. Yeah, and you'll feel it right there. See how easy that is to feel? Boom, you drop it in there. Now aspirate first because there's a little pump there, right? But you can feel it right there. Now you can go in anterior. That's a little scarier for me. I like to go just lateral, just slip it underneath the flexor carpi ulnaris. And when would you do that? Well, if you've got a laceration on the ulnar nerve distribution of sensation, which is the hypothenar eminence right in here, you've got glass in there, you've got a foreign body in there. Putting a needle in there is really painful for people. Swells the tissue up if you're doing a complex laceration repair on the hand. And so you're going to distort the margins of your laceration. So if you just put the block in there, this stays the same and you can close it. It's also good for boxer fractures. Now, people that need anger management, now I like to do a lot of carpentry and construction and building and stuff like that, and they sell these stud finders at various stores. I don't know if you have Home Depots or Lowe's or whatever your big construction stores are here. What they do is they stock 18-year-old males, and you go find the stud, and they go like this. Because, every 16 inches, there's supposed to be a 2x4, right? And the only patients I ever see are the people that, boom, they always hit the stud. So if you want to get a stud finder, find an 18-year-old male and ask him to punch the wall. That's where you hang the nail. It's just a theory I have. All right, hypothesis, I should say. All right, so you can do it for boxer fractures. Now, you can also do, this one shows a radial nerve block there, going in the front, but you can do median and radial nerve blocks. I don't tend to do those. They're a little bit more complicated, and you need to do it ultrasound guided. You got to be careful about, the radial artery and stuff like that. So you need to know your hand anatomy. And the hand anatomy, I'm going to be going through that later in another lecture, but I can go through it quickly here. There's sensory and motor for your three nerves, right? Sensory and motor for your three nerves. So your median nerve, that's easy right here. That's the sensation, right? Radial nerve is the back of the index finger, maybe to the third finger. And then the ulnar nerve is over here on the fifth digit, right? So median, radial, ulna, easy. Motor's a little harder, but I can make it really easy for you. Just remember, for motor, for the three nerves, the median nerve is the British nerve. Cup of tea. You go and grab the cup of tea, you pinch. That's all median nerve, right? You flex at the wrist. That's median nerve. You flex at the elbow. That's median nerve. You pronate and you sip your tea. Now you guys know median nerve, motor. Tea drinking. Pinch, index and thumb, flex at the wrist, flex at the elbow, pronate, you're drinking tea. Radial is very radical. Stop. Okay, so that's your extensors of your wrist. Your radial nerve do your extensors, and your ulna is your interosseous motor, right? So you get your ulnar nerve defect, right, from entrapment here. So it's your interosseous muscles. So that's your sensory and motor. And that comes into play when you're doing stuff. So like I said, a boxer fracture, a laceration, complex laceration, fishing out foreign bodies. All right, an infraorbital block. This is where you get to stick a needle near the eyeball. So I mentioned earlier about the VC border. If I get, somebody who didn't actually punch a wall, but it was an 18-year-old who punched someone else, and they cut their lip right here, and you want to put that lip together, right? But you don't want to swell up the tissue by doing a local injection right there. What you do is you do an infraorbital block. Now you've felt, right? You've felt your own femoral pulses. You've felt your anterior iliac spine. You've felt your neighbor's flexor carpi ulnaris, right? Just below the pupil there on your cheek, you'll feel a little notch. If you can't feel yours, poke someone else beside you, okay? Just poke them in the eye. Yeah, it's okay, corneal abrasion. And you'll feel right there, and there's that little notch right there. It'll be a little tender sometimes too when you're pushing directly on it. That's where you're going for. Now, anatomically, you can line it up from the pupil to the corner of the mouth, even if they're like got one of those eyes under the, like there's always somebody that's like, which eye do I look at? But really, it usually lines up from pupil to the corner of the mouth, right there on the cheek. Now, the thing is, though, you don't go directly into the cheek. You play dentist nights, weekends, and holidays. You lift this up, and you stick the needle up there, and you aim right for there. And you'll anesthetize that whole area in a block, and you can get great repairs, especially if you're concerned about cosmesis. You get great repairs. Now, there's the superior orbital block as well. The superior nerve comes right out here and along your eyebrow. About 1/3 along the way, you'll feel a notch right there. And if you've got a complex laceration on your forehead that you don't want to swell the tissue up, or you've got a bunch of stone and dirt that you have to dig out and it's going to take some time, put the needle right there. They'll be frozen on the top half of their forehead, and that works well. So you've got a supraorbital block and an infraorbital block. But the infraorbital block, you go through the mouth. The supraorbital block, you go through just above the eyebrow, not through the mouth. All right, so now we're going to talk about ears, and this is a scissor block. So this is a different kind of block. There are 4 nerves, actually 5, but 4 nerves that give sensation to the outer aspect of the ear. And so if you have some kind of laceration, defect, you've got an IND there, you've got something working on the ear that you need to spend time doing, right? What you do is a scissor block. 4 of the nerves you can get. The 5th nerve you can't. So you need to know that. The external auditory canal, the EAC, is where you put your finger, right? That's the external auditory canal. And the canal to the tympanic membrane, that's all a branch of cranial nerve 7. You can't get that with this block. So that's why people with Bell palsy will complain of ear pain, because of the 7th nerve involvement. Okay, so for a scissor block, what you do is you just put on either side superior and either side inferior, and you get a field block around that ear, and then you can work on the ear. It works really well, but you can't do it for the air canal or the tympanic membrane. So these are the people that get it, and I'm turning into an old man sitting on my porch saying, "Get off my lawn!" Because I see these people with these things that they dilate their earlobes, and they get them bigger and bigger and bigger, and I'm like, you know what that's tempting me to do? Right? Especially if I'm, anyways. And then you'll get these people ripping them out, and they'll rip their earrings out. These piercings now, they have like harpoons, like javelins going across their ear with a road of studs, and then they've got a stud in their nose. See, I'm starting to sound like that old guy. The stud in their nose, and then a chain between there and there. What's that tempting you to do? You just want to pull their chain, don't you? Is it just me? Or do you want to pull their chain? I want to pull. And it's usually they come up to you, I'm having a quiet drink with friends, and these 2 guys just jump me. And that's the picture in the top right-hand corner. Don't shout it out. Don't shout it out. This will be for a prize. If you know what that defect is in the top right corner, in the top right corner, come and find me after my talk, and I will give you a prize. So exciting. All right, so penile blocks, not as exciting. Now, we call this a scissor block too, but I would not recommend you come up to a man and say, "I'm about to do a scissor block on your penis," because there's running with scissors, and then there's scissors blocks. They're going to be scared, okay? So this is a field block of the penis. And same thing with the ear, though. You just go on either side, and you get a regional block that numbs the penis. So when would you use this? When would you do a penile field block with a scissor block where you inject on either side and get that regional anesthesia? Well, there's the classic case of getting their pants and their foreskin stuck in the zipper, right? Now, there's very classic presentation. Classic means 15% of the time. But the classic presentation it's a delayed presentation, because that man is going to find every tool in their garage to get this resolved before they come in. So it's usually a delayed presentation, and they have the 2 pant sign. So the one pant that got stuck, and then it's, "Honey, where are my pants?" And then they get the second pair of pants and come in with the second pair of pants. Because, the first pair of pants, there's foreskin stuck in the, whatever. So that's the one spot, the one case that you would use this on a foreskin stuck in a zipper. The other case is if somebody has a foreign body. Why would you pierce? I don't know. Again, I'm getting old. There's a generation gap happening. But you could have a Prince Albert ring. okay? And it may get stuck, and it may need to be removed, and it might be more humane to do a field block than just pulling on it. You're having a very bad sexual encounter if your Prince Albert ring is stuck on a clitoral ring. Those people usually come in together. Oh, good, you got that one. Okay, so difficult ankle blocks. This is to, I said we were going to do ankle blocks. If you want to do an ankle block, this is how you do it. Oh my God. Really, look at this. There's 5 nerves in there. I really think you need ultrasound guided to do these kind of blocks. Now, if you're an ultrasound POCUS guru, great, super, go for it. Go for that shimmering nerve, drop it in there. When it comes to ankle fractures, bimalleolar, trimalleolar fractures, things like that, I was talking to Greg Henry before this lecture. I'm just sending them down the K-hole. I'm giving them ketamine and I'm doing a procedural sedation. It's worth the paperwork. I know I can do this easier than I can do the ultrasound guided version of this to try to tick off every nerve. There are people out there that are really good at it, so I don't want to discourage you from learning this skill. But again, for these cases, I wanted to point out, hey, I feel the pulse. I'm just going to go lateral to that, 20 cc's. Oh, okay, right here, flexor carpi ulnaris. Go in there, aspirate. Nope, not getting any red stuff back. Great, drop in some local anesthetic. Very easy. Infraorbital nerve, very easy to do. This one, not so easy. So there are all the nerves. It's usually more done in the OR than in the ER, but as we get better and better in ultrasound, it may get easier and easier for us. And this is just the ultrasound guidance to show you how you do it. So when you get out the ultrasound and you look at that nerve, you'll see it there, and you'll see it shimmering. It's got a bit of a shimmer to it, and it won't show up on just a photo as opposed to a video. But you'll see that shimmering, and that's where you put your needle. That's where you get the when you inject, and that's when you get a great nerve block. But I hope that you now feel really comfortable about knowing your neighbor after you've felt them in various places. And you'll also feel comfortable going back to your own institutions and doing these nerve blocks. And I came down early this morning and I got to see Rick Bucata do the introduction. And what I really liked about that introduction was the fact that we have PAs, NPs, and MDs here. We work together. We care for patients together. I think we should train and learn together. So I really like this course and the way he's put it together. Thank you very much.